Record.
Okay, for the psoas, we're going to do a test. This pain pattern runs up along the spine. The range of motion test I like to do is a side-lying test where I'm lining the thigh up with the rest of the torso. My top hand now is going to come back and the thumb is going to lock into the ischial tuberosity. I should be able to pull her thigh back about 45 degrees, and I may be getting 1 degree here. Now, that test position also incorporates the tensor fasciolata, so if I lift her thigh up and come back, I get significantly more, telling me that most likely she needs more help with her TFL than she does with her psoas right now. But we're treating the psoas. Let's sit back up now. Okay, on your back. And scoot over towards me. And we're going to bend the knee up to stabilize. And I need you to find your belly button. Okay, umbilicus for all you scientific types out there. So we have the belly button, we have the AS-IS. I want to measure halfway between the two, and then I'm going to come a little bit below and step right in and put some pressure straight down. Now, almost always you're going to be able to palpate the muscle here. If there's a problem, I can have her lift her thigh up, and this will tighten up underneath me. Now, generally speaking, when the psoas shortens and tightens, it tends to very oftentimes cause or be part of an anterior tilt to the pelvis. If that's the case, we want to be working on the medial aspect of the muscle. If there is a posterior tilt, then we're going to want to go ahead and put more pressure back towards the lateral aspect of the muscle. So this gets the first position, and this is usually a very important position, but the other thing is the iliacus fibers we're going to come for. We're going to, again, bring both knees up this time. I'm going to locate the AS-IS, scoop around the inside of the pelvic bowl, keeping the mesentery on the outside and the inside of my hand against her iliac fossa. And as I come down, I'll be able to see where I'm allowed to go, and that's where I stop. And again, I want to wait and be patient. One of the things that actually happens quite a bit on this muscle is many people are incredibly tight, and in spite of all your best efforts, there's not much of a change sometimes after working this muscle. If that's the case, one of the things we want to look at is the deep front line. And the place I would start treating that would be in the deep posterior compartment of the calf, following up along the intermuscular septums along either side of the adductors, and then see if you get a release more so of the psoas. I almost always find that takes care of the problem. Now, the next position of the psoas that we want to look at, we're going to lower the leg, drop out into the thigh adductor position, and from this position we're going to find the AS-IS drop straight down below that to the sartorius tendon, and we want to roll medial off the sartorius tendon, and the entire lateral floor here of the femoral triangle is going to be made up of this muscle. So we're going to treat the iliopsoas muscle at this level, and then hopefully have some sort of change in our patient. So let's take that out and have you roll on your side, again, face towards the camera. Going to bend the knee, bring her back into that neutral position, and come back. And now we do have a change, even though we haven't treated the tensor fasciolata. As we come up and take the TFL out, we get even more range of motion for the psoas. Now, the stretch for this that we're going to have her do, go ahead and stand up. I'd like a standing psoas stretch, so you can stand up into a fencer type of position. And the idea in this position is she leans forward, her back leg is straight, her front is bent, and if she tips her pelvis so that the pubic symphysis comes towards the ceiling, she'll feel a pull along the top area there where the psoas comes through. Again, I like to have people do this at work. This is one that they can do regularly.